Hello and welcome to Noon Conference hosted by MRI Online. Noon Conference connects the global radiology community through free, live educational webinars that are accessible for all and is an opportunity to learn alongside top radiologists from around the world. You can access the recording of today's conference and previous Noon conferences by creating a free MRI Online account. Today, we are honored to welcome Dr. Tatiane Cantarelli for a lecture entitled Imaging for Sports-Related Finger Injuries. Dr. Cantarelli is a MSK radiologist based in Sao Paulo, Brazil. She completed her clinical MSK fellowship at HCOR, where she continues to practice. She also has a strong research background, having completed a research fellowship at NYU. Dr. Cantarelli is an active member of several radiology societies and has authored numerous publications on MSK radiology. She's passionate about education, frequently lecturing at Brazilian radiology meetings and international radiology meetings, and is deeply committed to training the next generation of MSK radiologists. At the end of the lecture, please join her in a Q&A session where she will address questions you may have on today's topic. Please remember to use the Q&A feature to submit your questions so we can get to as many as we can before our time is up. With that, we are ready to begin today's lecture. Dr. Cantarelli, please take it from here.
Thank you so much for the introduction, and thank you everyone for attending. So I'm glad to be here talking about sports-related finger injuries, especially during the Olympics. So let's start. There's no conflict of interest. So about the background, when it comes to sports injuries, hand injuries are usually traumatic, and lesions may occur from falls, axial loadings of digits, or rotational force due to grasping activities. So the PIP, the proximal interphalangeal joint of the fingers, is the most injured joint in sports, following by the metacarpal phalangeal and carpometacarpal phalangeal joints of the thumb. So radiologists need to understand the anatomy and the full spectrum of fingers and thumb abnormalities and associate imaging findings. So hand and wrist injuries are common occurrence in all sports, and many of them are sport-specific, like the mallet finger for the baseball. Mallet finger also can be found in basketball, the Boutonnière injury, the distal interphalangeal injuries, the boxing injuries like the box knuckle, boxers fractures, bowling, we have the neuroma of the ulnar digital nerve of the thumb, football or rugby, we have metacarpal fractures and the jersey finger. Rock climbing, flexor Pulley lesions, Volar plate, and flexor tendon injuries. And for skiing and snowboard, we have the UCL stumps injuries, the skier's thumb or gamekeeper's thumb. And the volleyball, we have fingers injuries and the UCL thumb injuries as most commonly relate to these sports. So some learning objectives of these presentations is to discuss the role of image in diagnosis and management of different traumatic sports-related hand injuries. Is to review the main anatomical regions and structures of the finger and to describe and recognize the features of these lesions that the radiologist must look for in order to do an appropriate clinical approach to the diagnosis based on the image findings. So image plays a key role in the evaluation and treatment planning of hand and wrist injuries, depending on the suspected injuries. So a combination of conventional radiographics, computed tomography, the CT, the MRI, and the ultrasound may be indicated. Osseous injuries of the hand often are diagnosed based on a combination of clinical examination and simple radiographs, not necessarily needing further studies like MRI or ultrasound. Initial radiographs, which consist of at least 3 views of the affected area, the PA, the oblique, and the lateral. CT should be obtained using thin slices that can be reformatted any plane. Usually they are used for surgical planning indications. And the superior contrast resolution of MRI makes it the modality of choice for evaluation of suspected soft tissues injury and the hand and wrist. And ultrasound also is a useful tool in the evaluation of hand and wrist pathology, particularly given its dynamic nature, the ability to compare with the contralateral side, the relative accessibility and relatively low cost, and also the lack of ionizing radiation. So first, let's talk about the finger. So when it comes to the fingers, there are many important ligamentous and tendinous structures that we need to be familiar with. Here we have some diagrams from the proximal interphalangeal joint. Some of the ligamentous structures include the proper and the accessory collateral ligaments. the UCL, ulnar collateral ligament, and RCL, the radial collateral ligament. And these ligaments help to stabilize the finger joints. In addition to these ligaments, there are also important tendinous structures to consider at the PIP, such as the extensor tendon central slip, and as well the volar plate here. And it's crucial to have a basic understanding of these ligamentous and tendinous structures to evaluate properly this joint. So in addition to bony structures, ligaments, flexor and extensor tendons, there's a particular structure that deserves special attention when examining the hand and fingers at the MCP joint, the sagittal bands. So is this structure here? The sagittal bands, this structure here, consist of fibrous structures that run along the top of the metacarpophalangeal joint. So these bands are essential in maintaining the proper alignment of the extensor tendons, which allows for smooth and efficient movement of the fingers. So another important anatomical structure that we need to be familiarized is the finger's Pulley system. The Pulley are a series of fibrous bands that surround the flexor tendon, keeping them close to the bones and preventing them from bouncing from the joint as they contract. About the finger injuries, the MCP and the phalangeal fractures are common injuries in the hand and fingers, often resulting from falls, direct impact, or twisting force. So these fractures can be classified as extra or intra-articular. Usually they are extra-articular in this location. And the pulley injuries are also frequently seen in sports, especially in competitive climbing. The A2 pulley is located at the base of the proximal phalange and is the most commonly affected pulley in the fingers. So the proper diagnosis and treatment of those lesions are crucial to prevent further damage and restore the function of the joint. So about the PIP joint, the injuries of the joint are common and can result from various forces applied to the joints. Collateral ligament injuries are often caused by axial load and dorsiflexion force that typically occur at the proximal attachment of the ligaments. So usually at the level of the middle phalanx, not the distal, so the proximal attachment of these ligaments. So dislocations are common and are frequently seen in ball handling sports. Dorsal dislocations are the most common type and are caused by hyperextension with axial loading, while volar plate injuries are typically caused by injury at the distal attachment at the level of the base of the middle phalanx, with or without an avulsion fracture of the base of this phalanx. Volar dislocations, including straight volar, lateral volar, or rotatory types, are typically caused by varus or valgus force coupled with a volar thrust to the middle phalanx. So fractures and dislocations often occur through a similar mechanism as dorsal dislocations, and isolated combining injuries to the volar plate are common, and distal injuries are often caused by dorsiflexion and axial load stress. So it's like when a ball hit the tip of the finger can occur. So the proximal or membranous portion of the volar plate can also be affected by intra-articular fractures, including the condylar fractures, T-bicondylar or comminuted fractures. So let's begin with the case of tendon injuries. So the first is the jersey finger or rugby finger. So this first injuries is occurred due to an avulsion of the flexor digitorum profundus tendon for the volar aspect of the distal phalanx base. Here, the flexor, the flexor digitorum profundus, it's detached, or you have a bony avulsion of this tendon, and it's typically caused by a sudden hyperextension of an actively flexed finger, such as grab an opponent's jerseys during rugby or football, or as you can see here, or in soccer, as we saw at the Brazil and Spain match during the Olympics this week. So the fourth finger is the most commonly affected. You can see here is not flexed as the other. So it lost the flexion position of this finger. And one of the symptoms is, as I say, is the inability to flex the finger at the IP joint. Here is not flexed, along with slight extension at this joint. So if jersey finger is not correct surgically, the finger will be still able to function, but the active motion of the injury finger will be very limited. There is a classification system for this injury based on tendon retraction and bony avulsion. So the type 1 involves the tendon being unfolded without fracture and retract to the palm. The type 2, the tendon retract to the level of the PIP. The type 3, a large avulsion fractures that limits the retraction to the level of the distal interphalangeal joint. And this fragment become caught in the A4 pulley, preventing further retractions. And the type 4 is a combined avulsion and tendon avulsion for the bone fragment, resulting in a double avulsion with subsequent retraction of the tendon, usually in the palm. And the type 5 involves a ruptured tendon with bone avulsion with bone comminution of the remaining distal phalange, which can be extraarticular or intraarticular. So this ultrasound image at the longitudinal plane at the PIP level, the jersey finger, you can see the avulsion of the flexor tendon with a bone fleck pointed by this yellow arrow. So, and you can see here the tendon retracted for this insertion and a cortical irregularity at the base of the distal phalanx. This is another case of a jersey lesion demonstrating a complete rupture of the fourth flexor, a digitory profundus tendon close to the insertion of the distal phalanx. We don't see the tendon here. As you can see here in the axial, there's just fluid at the level of the tendon insertion. There's soft tissue edema, and the tendon is retracted here. You can see the tendon undulated here at the proximal level, completely retracted. Moving on to the Boutonnière injuries, they are caused by a disruption of the central slip of the extensor digitorum at its insertions of the base of the middle phalanx. So this results in patients present with a flex PIP. Here you can see flex PIP and a hyperextended distal interphalangeal joint. So this is the aspect of the Boutonnière deformity. These injuries are most commonly seen in basketball and volleyball plays, and plain radiographs are used to assess the presence and degree of bone involvement in addition to joint reduction and alignment. So this deformity happens because we have a progressive volar displacement of the lateral bands, making this DIP joint be hyperextended. In the first case here, we can see a male patient with deformity affecting the 50th finger. We see the Boutonnière deformity, the flex DIP, and the hyperextended PIP and hyperextended DIP. So ultrasound image at the longitudinal plane show the disrupted central slip of the extensor tendon, which is indicated by this yellow arrow here and here. And there's no bone avulsion evident in this ultrasound. It's important to note that the deformity results here in a flexed proximal interphalangeal joint and a hyperextended distal interphalangeal joint. Here we have radiographs in 3 positions of these patients, a 34-year-old man present with edema at the PIP joint following trauma. So this results in a Boutonnière deformity of the third finger. So we see at the oblique view, a lateral view of the fingers, the hyperextended distal and the flexed proximal interphalangeal joint with soft tissue swelling around this joint. So these same patients underwent an MRI, and you can see the disrupted central slip here at the level of the insertion at the base of the middle phalanx. We can see here also the disrupted central slip and the volar displacement of the lateral bands here, pointed by these red arrows. We can see here also at the coronal plane. The next lesion, the Mallet finger, is a finger tendon injury caused by a disruption of the terminal extensor tendon at insertions of the distal phalanx. As you can see at the graphic here, a disruption of the distal tendon, terminal extensor tendon. So it's considered the most prevalent finger tendon injury in sports. So Mallet fingers injuries may represent an isolated tendinous injury or occur in a combination with a avulsion fracture of the dorsal base of the distal phalanx. And when assessing Mallet finger injuries, the percentage of articular surface involvement on X-rays must be reported because bone fragments with greater than 1/3 involvement of the articular surface may require fixation. So it's important to accurately diagnose and treat mallet finger, also to present long-term complications such as joint stiffness, deformity, and loss of function. So in this case, we can see X-ray image, like in front and oblique views, and it's a close view of the fourth distal phalanx. So we can see the bone fragment here at the insertion of the terminal extensor tendon. In this other case of a mallet finger, the X-rays looks normal with the exception of the flexed fingertip. We see a little bit flexed, the fingertip. However, upon examination with ultrasound, we can see a disruption of the terminal tendon. We can see fluid here at the level of the terminal extensor tendon and at its intersection of the distal phalanx. You can see here again the disrupted extensor, the terminal extensor tendon. In this other case, we can see the same injury, the mallet finger on MRI. On the sagittal fluid sequence, we can see the disrupted tendon. Here the same at the axial at the level of the injury. Also, we can see the fingertip a little bit flexed during this examination. This other case, instead of a tendon tear, the patient had a avulsed bone flake from the dorsal side of the distal phalanx. We can see here evidence the corresponding defect in the phalangeal base. We can see there are some is missing some bone here, and there is a retraction of the terminal slip here. We can see this echogenic structure is the terminal tendon attached to the bone flake. Another case also with a bone avulsion on MRI. We can see the bone and the terminal slip attaches to the bone fragment and a little bit retracted. So now let's discuss another type of injuries, the box knuckle. So the box knuckle is a condition characterized by the disruption of the sagittal band, which leads to instability of the extensor tendon and can also cause tears in the MCP capsular ligaments and damage to the articular cartilage. So these injuries are highly prevalent among boxers and is often sustained when landing a punch. And it most commonly occurs in the third MCP joint because it's more superficial, it's more prone to injuries. So this central tendon typically dislocates medially because, like you can see here, because the radial band is more prone to rupture owing to anatomic weakness and the tendency of MCP joint to be deviated to the ulnar side. So in this case of box knuckle, you can see the soft tissue swelling of the third MCP joint. At the ultrasound, we can see injury, a lesion of the radial sagittal band. Here, we can see there's a gap. You can see the ulnar sagittal band intact, and there's a fluid collection at the level of the radial sagittal band. And when it's flexed, the finger, we can see the extensor digitory commonis tendon subluxated to the ulnar side, is located to the ulnar side. Now let's discuss the finger ligaments injuries. So in this case, we present an 18-year-old male goalkeeper who was reported experiencing right finger pain after hyperextension. So upon MRI, axial and coronal T2 weight facets image reveal a sprain of both radial and ulnar collateral ligaments at the PIP joint of the fourth finger, although there's no evidence of ligament disruption. So there is also associated soft tissue edema, but the ligaments are intact only with edema surround them. In this other case, 55-year-old goalie also experienced left finger pain following trauma during soccer training. And during the examination, the coronal and axial T2 fat set suppressed image reveal a partial tear of the collateral ligament at the origin of the radial collateral ligament at the level of the PIP joint. We see some irregularity of these ligament fibers. As I said previously, usually the injuries are located proximally, not distally, so at the level of the middle phalanx. So now let's discuss the volar plate injuries. in case of volar plate injuries, knowledge of the orthopedic ito classification is crucial, as it helps in determining the management of the management plan. So the decision treatment depends on various factors, including the size of the fragment, if it's less than 40% of the articular segment, the degree of impaction, and the direction of the dislocation. So the ito classification includes 3 types of volar plate avulsions, injuries of the PIP joint. So ito type 1 involves a hyperextension mechanism of injury with avulsion of the volar plate and a longitudinal tear of the collateral ligaments. And the ito type 2 is a dorsal dislocation with avulsion of the volar plate and a complete tear of the collateral ligaments. And ito type 3 is divided into subtypes. The 3A involves a fracture dislocation with a avulsed small fragment that less than 40% of the articular surface. And the type 3 involves a fracture dislocation with a fracture impaction of the articular surface of more than 40%. So in this case of volar plate injuries, it's on type 3. There's an avulsion fracture. We can see a tiny bone flap here at the level of the PIP joint. This fragment is related to the avulsion at the volar plate at the base of the middle phalanx. So, but there's no evidence of dislocation of the proximal interphalangeal joint at this exam. So in this case, a 70-year-old male present with left finger pain following a hyperextension injury while playing soccer. So we can see a partial tear of the volar plate. So we can see here a gap at the sagittal image, and the axial, we see this area of the partial tear. So there's no much retraction of the volar plate because still there are some fibers located more at the ulnar side than the radial side. And also the tendons are preserved. This is another case. So we have displaced volar plate injury. So the sagittal and axial T2 weight fat suppress image, the volar plate is located at the central position. Here we can see 2 fragments of the volar plate, and also with a gap here. The tear is here, and we can see here the volar plate retractly proximally. And also there are some bony contusions associated, but no bone fragment avulsed. Another case now in ultrasound showing a longitudinal image of a volar plate tear, but in this case it's not distal, because let me just go back here, is the distal portion. Here we have the membranous portion. So in this case it's proximal, so it's the normal side and the side with the injury. We can see this fluid fluid at the membranous portion of the volar plate, like the proximal segment of the volar plate is injured. And the Pulley injuries, let's see some case. So the climber's finger is a common injury among rock climbers. It's caused by strain or tear in the tendons and pulleys that control fingers' movements. So the most commonly injured pulley is the A2, followed by the A4. So the A2 pulley is located at the base of the finger, while the A4 pulley is located at the middle of the finger. So you can see here the A2 pulley, and here the A4 pulley, the most commonly injured pulleys. So the mechanism of the injuries often occur during crimping, when the fingers are bent at the first joint and the hand is held in a closed fist position. When a climb's foot slips unexpectedly, it puts unexpected force on the hand, causing the pulley to stress or even tear. So symptoms of climber fingers often include an audible pop and immediate pain, followed by swelling and possible bruising later. So it's a case of a 35-year-old male present with post-traumatic pain in his right third finger, along with a feeling of a pop. So upon examination, the ultrasound transverse image revealed an abnormal thickening and hypoechoic port annular flexor pulley A4 here. For the examination through longitudinal ultrasound image depict an increased distance between the tendons and the diaphysis of the middle phalanx of the right third finger. So another case on ultrasound of finger pulley injury. So the ultrasound transverse and longitudinal ultrasound image shows an increased distance between the flexor tendon we see the tendon here and the distance to the cortical bone of the phalanx, the middle phalanx, and the proximal phalanx. This was more proximal, so it's related to the second Pulley injury with a bowstring of the tendon. We can see here the distance between the tendon and the phalanx and the normal side. It's very close, the phalanx to the tendon here is very distant. Now on MRI, so it's a case of acute A2 Pulley injury with a patient who was practicing indoor climbing. So an MRI image of the affected finger shows increased distance between the flexor tendon of the forefinger and the proximal phalanx. When you compare to the normal side, you see it's very close in here. There's a increased distance between the tendon and the bone. Additionally, there's tenosynovitis and also the disrupted Pulley. We don't see all the fibers. Another case in a chronic setting of A2 Pulley injury involving the fifth finger occurred 3 months ago. So the MRI image show increased distance between the flexor tendon of the little finger and the proximal phalanx, resulting in a bowstrings appearance of the tendon. You see again the increased distance between the tendon and the bone and the normal tendon, and the relationship with the bone is maintained. Let's move to the bone injuries. So let's discuss about the box fractures. They are minimally comminuted transverse fractures of the fifth metacarpal neck. They are considered the most common type of metacarpal fractures. Usually they happen as the result of punching a hard object like a wall with an unprotected fist. Typically, they are diagnosed through X-ray. They don't need advanced image like MRI to the diagnosis. So this is a case of X-ray, like the front oblique and lateral views, showing the distal fifth metacarpal fracture involving the neck. You can see here a deformity with palmar angulation, which is typical for this type of fracture, the boxer fracture. Now let's focus on the thumb. There are several specific injuries related to the thumb. So again, let's review some anatomy. So the thumb has important ligaments included in the ulnar collateral ligament at the MCP joint. Close to them, there the accessor UCL and the most volar aspect. So these ligaments are common injuries and require attention during evaluation and treatment. The thumb also has some important ligaments at the volar aspect related to the sesamoid bones and the volar plate, including the phalangoglenoidal ligaments distally and the chakrane ligaments proximally here, the chakrane and the phalangoglenoidal ligaments. And lastly, the thumb also has a flexor pulley system that includes the first and second pulleys here and here, as well the variable and oblique annular pulleys, the variable and oblique. The injuries of the thumb CMC joint are commonly associated with fractures such as Bennett's fracture. So dislocations without fracture is rare and involve the rupture of the volar beak ligament with dorsal displacement of the first MCP joint, first metacarpal bone, actually. The thumb metacarpal phalangeal joint is also prone to several common injuries, include dorsal dislocations caused by hyperextension with complete rupture of the volar plate, usually proximally. So collateral ligaments injuries are also very common, including Skier's or gamekeeper's thumb, which is caused by radial directed force on abducted thumb. Another specific injury is Stener lesions, which occurs when the distal portion of the UCL avulsions from its attachment of the proximal phalange and herniate through the adductor aponeurosis. Let's see some ligaments injuries. So let's start with the most famous, the Skier's thumbs or gamekeeper's thumbs. So Skier's thumbs and gamekeeper's thumbs are two similar injuries that involve the thumb. So Skier's thumbs is an acute injury that occurs due to trauma for hyperabduction of the thumb, as is caused by the ski pole strap, as you can see here in this image here. On the other hand, gamekeeper's thumb is a chronic, non-traumatic overuse injuries that greatly injures the ulnar collateral ligament. So gamekeepers who killed small animals were observed to have this injury due to repetitive trauma. So the term gamekeepers was coined in 1955 in Scotland. It actually refers to a gamekeepers breaking the necks of the animals primarily have. This is from the original paper, which described this injury. This X-ray showed an avulsion fracture at the ulnar corner of the base of the proximal phalange of the thumb, characteristic of gamekeeper's thumb. There's also a classification of Skier's thumb that was proposed by Hintermann in 1993, and it's based on whether a fracture is present and whether their injury is stable, resulting in 6 types, where the types is 2, 4, and 6 requiring surgery. So the X-ray and the diagram show multiple small fragments of bone at the attachment of the ulnar collateral ligament of the first metacarpal phalange joint. So this is type 1 Skier's thumb lesion. Here we have an ultrasound image, longitudinal image at the level of the MCP joint, revealing an avulsion fracture. You can see the bone fracture, the bone avulsion here at the site of the attachment of the ulnar collateral ligament. So the ligament appears hypoechoic. However, both the ligament and bone flake are located deep to the aponeurosis. We have here the aponeurosis and the bone fragment and the ligament are deep. So there is no formation of pseudomass at this level. We can see here the aponeurosis, they are deeply located and they are asymptomatic, showing the normal aponeurosis and the normal ligament. So this is a case of a 40-year-old goalie had an injury after hyperabduction of the thumb. So longitudinal axial T2 fat suppressed image reveal a complete distal tear of the UCL with the ligament stump and retracted here, pointed by this red arrow. So there's some bone edema, and the radial collateral ligament is normal. So this is an example of a UCL tear without a Stener lesion, when the ligament becomes trapped or the adductor aponeurosis, so is located deeper to the aponeurosis, not superficially. So there is no Stener lesion in this case. And now let's talk about the Stener lesion. The UCL normally lies deep to the adductor pollice tendon, and a Stener lesion is characterized by the slippage of the torn end of the ulnar collateral ligament superficial to the adductor aponeurosis, or adductor pollice muscle becomes superficial to adductor aponeurosis. So this causes the adductor aponeurosis muscle to be interposed and preventing proper healing. And in those cases, surgical repair is necessary to correct these injuries. As we can see here, we can see the Stener lesion, the ligament trapped superficially to the adductor aponeurosis. So this is a case of a Stener lesion in a 35-year-old patient with thumb pain after trauma. So axial and coronal MRI show a torn and retracted ulnar collateral ligament. We can see here the aponeurosis and the ligament retracted and superficially located to the adductor aponeurosis. So this is a classic Stener lesion of the thumb. We can see these lesions using ultrasound. So ultrasound findings, in this case, here we have a symptomatic side of the MCP showing the ulnar collateral ligament absent. There's no here, and there's a pseudomass here, retract at the level of the metacarpal head. So performing a stress view, there is a significant open of this articular, the joint space with herniation of periarticular soft tissue into the joint. So this is caused by the ligament tear, which is retracted here, this pseudomass. Another case, now talking about volar ligament injuries of the thumb. So this is an 18-year-old male patient, soccer player, that sustained a thumb volar ligament injury. So sagittal and coronal T2 weight fat suppressed image reveal a complete disruption of the radial check brain ligament. We can see this gap with bony edema of the radial sesamoid, and there's with some edema of the muscles of the tendon region of the hand. And another thing we can see here, the ligament retracted. And distal dislocation of the radial sesamoid when compared to the ulnar sesamoid. Sorry. This is another case, a 70-year-old male soccer player. So sagittal T2-weight image review at volar ligament injury. Show again completed disruption of the ulnar sacral ligament. We can see here the gap with fluid-filled and edema of the muscles around the joint. And additionally, in this case, we have a sprain of the phalangoglenoidal ligament, which is distal. So you can see signal alterations and edema around this ligament, but without a clearly tear. Also, we have volar plate injuries of the thumb. So the ultrasound image showing volar plate of the MCP joint of the thumb. This is the normal side. This is the injury side. The image indicates a tear at the proximal portion of the volar thumb plate. We can see this hypoechoic area, which corresponds to the tear. And here, the volar plate retracted and insinuated at the joint space. Here we can see the normal volar plate of the thumb. No, also during the flexion, they continue the movement without herniation into the joint space, and compare it with the injured side, when we can see a dislocation of the metacarpal head and insinuation of this volar plate into the joint space. We also can have Pulley injuries of the thumb. It's not common as we see at the fingers. So in this, this is a case of a 70-year-old male goalkeeper present with pain after trauma of the thumb. Axial and sagittal T2-weight fat suppressed image show thickening and irregularity of the first annular pulley indicated by this red arrow. You can see here the irregularity. Additionally, there's tenosynovitis, which can be associated in this injury. You can see the tendon sheath filled with fluid, but without tendon disruption, and some diffuse edema of the thenar muscle related to the bone contusion, direct bone contusion in this patient. Lastly, we have bone injuries of the thumb. So Bennett fractures, the most common fracture involve the base of the thumb. So intraarticular fracture is that intraarticular fracture that separates the palmar ulnar aspect of the first metacarpal base from the remaining first metacarpal. We can see here this longitudinal fracture. The bone fragment separate the palmar aspects, palmar ulnar aspect of the first metacarpal base and the remaining first metacarpal. The injury mechanism can be seen in boxing, but is also commonly seen in sports such as football or rugby, and is usually caused by a hard impact or trauma, such as punching something hard or falling onto your head, with the thumb sticking out of the side. So there's another fracture, it's called a Rolando fracture, that is very similar to the Bennett fracture, but it's most related to trauma with high energy, which it's a fracture of the base of the first metacarpal, but it's a comminute fracture. Different for the Bennett fracture is a longitudinal single fracture line at the base of the first metacarpal. So this is the first case, a radiographic case. A 30-year-old male patient presents with a Bennett fracture. So the X-ray shows the two-piece fracture of the base of the thumb metacarpal bone. He is in the front view. You can see the line, the bone fracture at the palmar and ulnar aspect of the bases. Is an intraarticular fracture. So so the fracture has an intraarticular extension, dorsolateral displacement usually. And this is fragments of the first metacarpal bone can be attached to the anterior oblique ligament, and which continues to articulate it with the trapezium. And also, in this case, we can have lateral retraction of the first metacarpal joint to the abductor pollicis longus. So can have a displacement of the metacarpal remain bone. This other case, also of bone fracture of a 30-year-old male experienced a fall resulting injury to the hand, which present with swelling and tenderness of the base of the first metacarpal bone and painful thumb movement. So CT and X-ray reveal an intraarticular fracture. In this case, a smaller fragment than the last case. With mild displacement of the base of the metacarpal bone. You can see here clearly at the CT, these oblique fracture lines tend into the articular face. So usually the CT, they are ordered not for the diagnosis, which you can see clearer by the X-ray, but to preoperatory planning, not for the diagnosis. So in conclusion, finger thumb injuries are extremely common, not only in athletes, as we can watching the Olympics, but also in recreational athletes. So image is used with frequency in order to help in the evaluation of patients present with suspect ligament and tendon injuries of the hand and wrist. And you have to use the method that which available for you. Whether it's ultrasound on MRI or X-ray, you need to be comfortable with the method that you are using to diagnose these types of injuries. And image can lead to an appropriate diagnosis and better patient management, as untreated injuries can lead to chronic pain, instability, and reduced function of the affected limb. Here's some reference. And thank you for watching. Thank you for your attendance.
Thank you so much for that lecture, Dr. Cantarelli. At this time, we will open the floor for any questions. So if you have a question, go ahead and put it into that Q&A feature so we can get through as many as we can before we need to leave. Dr. Cantarelli, if you could open up that Q&A box at the bottom, you got a couple in there so far.
Okay.
Let me know if you want me to read them out to you.
Let me see if I can open here. Try to find it.
No worry. How about I read the first one out to you and then we will find it. The first question is, how will we differentiate boxer versus barroom fracture radiologically?
Just a minute. I'm trying to close here my slides. Can you repeat the first question? Just a minute.
Sure.
Okay. Now, okay, I can see here. Okay. So usually these fractures, we use simple X-ray. So the boxer is more distally, so more in the neck. Usually the barroom is more proximally, but it's basically the same mechanism to hit a wall, unprotected. Like you can punch a wall, you can fight it, but it's basically the same. What is the image protocol of unsure fractures? I think it's asking probably the MRI protocol to diagnose probably image. Because the protocol that we have in our service to finger injury, we usually include an X-ray, because sometimes in the acute setting of the X-ray, the acute setting of the injury, the MRI, there's so much edema that we cannot see like small bone fragments. And the protocol to MRI to detect this image, like if there's a negative X-ray, we use a small slice, like 2 millimeters, focus on the articulations to see the ligaments with more high resolution. So we include the 3 planes, T1 without fat saturation, and 3 sequence, axial, sagittal, and coronal planes of with steer or T2 with fat saturated sequence to diagnose these injuries. rarely we use like CT. It's more usually for fingers, X-rays are enough to see the bone fragments. The other questions, do you have an experience using MRI finger coil? Yeah, we use MRI finger coil, but we usually use because most of the time the patient, some case they came to evaluate a specific lesion like a mallet finger or so we use this kind of coil. Another injuries like we have like tendon injury, use the hand coil to have a more broad view of the structures, but we use mostly the finger coil to evaluate the nail plate. With distal injuries of the nail, use a direct a small field of view to see fingers, usually the distal interphalangeal joint, not the proximal interphalangeal joint. So it's mostly used to distal injuries, traumatic, or to evaluate the nail. Someone asked, all the patients with finger injuries should undergo ultrasound with X-ray. If you have they available, I think it's better to have both, but not. Sometimes the patient don't. You can choose like between MRI or ultrasound, which is more available for you. Sometimes the ultrasound is easier, is at the emergency room. You have more confidence to evaluate it and use the MRI. MRI you need to schedule the patient. So depends what is available. But X-ray, I think it's always a good choice to primarily evaluate in these injuries to exclude some bone fragments. Someone asked if it's mandatory to report all injuries or enough to say which surgical versus conservative. I always report all the injuries. Obviously, I report with more detail the one was each surgical, say how much the area of the articular surface is affected, is 1/3 or more than 50% depend of the injuries, but I report all the injuries because sometimes they change the treatment with a combination of the lesions that you see, not only for one. So sometimes you have a partial tear, but you have partial tear of a lot of structures, and they will not go in so much conservative to the treatment. I think most of the questions were.
I think you got all the questions. Yes.
Yeah, there's a lot of questions.
A lot of well, thank you so much for answering them all, and thank you so much for your excellent lecture. We really appreciate you here today.
Thank you so much for the invitations.
Absolutely. And thank you all for participating in our noon conference and asking such great questions. You can access the recording of today's conference and all our previous noon conferences by creating a free MRI Online account. We will also email out a link to the replay later today. Be sure to join us next week on Thursday, August 15th at 12 p.m. Eastern, where Dr. Basak Dogan will deliver a lecture entitled Artificial Intelligence at the Heart of Breast Imaging, Innovations and Insights. This is going to be co-sponsored with AAWR, so don't miss this. You can register for it at mrionline.com and follow us on social media for updates on future noon conferences. Thanks again and have a great day.